Hello, I want to welcome you and thank you all for being with us tonight. Throughout this pandemic, Stanford Medicine has put the safety of our patients, staff, and community at the center of every decision that we've made, including the difficult decision to move tonight's event online. While we were looking forward to seeing many of you in person, we're excited to be able to bring this remarkable group of faculty and students presenting live right here from the Assembly Hall in the new Stanford Hospital. We come together today to learn about the potential impact of their incredible research and discoveries, and to celebrate the unifying power of humanity on our community. Craving a sense of connection during this isolation caused by the pandemic, our Stanford Medicine community found inspiration through the restorative power of music. A series of online stuck-at-home concerts were created, and they brought the much-needed joy of live music performance back to our lives. Each month, our students, staff, and faculty, and their families shared their musical talents, performing virtual concerts that became a popular source of hope, comfort, and resilience during an incredibly challenging year. Today, we are so pleased to share some of that musical inspiration and connection with you in the form of a very special performance. It is my honor to introduce our own Dean Lloyd Minor, who will join Dr. Condoleezza Rice to open today's program with a performance of Robert Schumann's fantasy pieces, Opus 73. Thank you again for being with us today. For all of the support of Stanford Medicine, we hope you enjoy the performance and the program.
Hello, I'm delighted to be with you to introduce this evening's program. Before I tell you about tonight's impressive group of speakers, I want to thank Dr. Rice for the privilege of being on stage with her. She and I share a deep appreciation for the positive impact and therapeutic value of music. It was a great honor to perform with her and to bring that performance to you at home. We're equally pleased to bring to you a program filled with some of Stanford Medicine's most innovative and creative researchers and clinicians. These biomedical pioneers will discuss their groundbreaking work and its potential impact on the future of human health. We also have with us students from both our MD and MD-PhD programs who will share stories of their remarkable paths to Stanford, as well as their future aspirations and the critical role philanthropy has had on their educational and career choices. While COVID-19 has taken so much from us, it has also given us a renewed appreciation for the critical importance of thorough, science-based medical research and investing in equitable and accessible health care. The lessons we have learned at Stanford Medicine throughout the pandemic will help us be better prepared, not only for future pandemics, but to more effectively advance solutions for a wide range of diseases. We are all stronger from this shared experience and energized by the potential to apply what we've learned to more rapidly accelerate discoveries into treatments. We remain grateful to all of you for your continued support of our mission and for your dedication to furthering science to benefit humanity.
How do you develop treatments for a disease you've never seen before? That was the question at the back of my mind in December 2019, when the first reports of a novel coronavirus began trickling out of China. At the time, I hoped it would be like the original SARS, a virus that caused a serious but brief outbreak that was controlled with public health measures before we had the need to develop new vaccines or treatments. But as December rolled into January, the question of how to work with a new virus was moving to the front of my mind. I was initially hesitant to jump in. After all, we had limited facilities for such work at Stanford, and I'd never worked with coronaviruses. In fact, very few labs in the entire world had expertise in this class of viruses. But I couldn't help but think, if we didn't do it, who would? Around this time, my infectious disease fellow, Arjun Rustagi, happened to be at the University of California, Irvine, undergoing Biosafety Level 3 training. Biosafety Level 3, or BSL-3, refers to the level of containment required for the most dangerous pathogens that can be transmitted through the air. And it's used for viruses like SARS-CoV-2 or for bacteria like tuberculosis. On January 30th, Arjun texted the lab this picture. And the caption read, "I'm ready for the novel coronavirus." It was meant to be a joke, but it got a little less funny the very next day when we had our very first case of SARS-CoV-2 reported in Santa Clara County. Arjun returned home and we got to work, learning everything we could about this class of viruses, taking knowledge from SARS and MERS to develop protocols to safely work with the virus. But at the time, the BSL-3 laboratory was this facility, a temporary biobubble built to support my colleague Carolyn Bertozzi's tuberculosis work. Carolyn was generous enough to let my lab and several others also do work in this facility, but its space was very limited. It was 280 square feet, and it had room only for 2 people to work at a time, maybe 3 if you were going to be a little unsafe, and 1 incubator for growing virus. It quickly became apparent that we needed a better place to do this work. And in partnership with the amazing Innovative Medicines Accelerator, we were able to identify a donor who funded the building of a 4,000 square foot state-of-the-art BSL-3 facility where this work is ongoing. And in fact, now it's not just my lab in there. It's 10 different labs doing work ranging from testing repurposed drugs for their ability to inhibit SARS-CoV-2 because these could be rolled out more quickly into patients, or identifying very basic mechanisms of how the virus enters a cell so we can develop entirely new drug classes, or employing state-of-the-art techniques like growing lung organoids, which are mini lungs we can grow in a dish, to really dissect the details of how this virus causes disease. And all of it aimed at developing new treatments to stop the virus in its tracks. Now, this work can't happen in isolation, and at the same time, there was a need to understand what is happening in actual patients infected with this virus. So to this end, in March 2020, we began biobanking samples from patients infected with COVID-19, starting first in our intensive care unit with the sickest patients, and then moving on through the leadership of our emergency department, Dr. Blumkons and others, capturing patients across the entire spectrum of disease from mild to severe. And these samples really hold the key to understanding how to develop new treatments, because we need to understand the severe outcomes in order to see what went wrong in that immune response. But there's equal value in the mild cases to know what went right. And in the ideal world, we'd be able to identify the pathways to turn one of those bad responses into a good one. And of course, we can iterate with our knowledge in the BSL-3 and the models we're building in order to test these ideas. Importantly, we were able to rely on our donor network to very quickly and nimbly build this biobank without relying on the sometimes creaky grants system. And this allowed Stanford to perform some of the earliest, the best, and the most comprehensive immune profiling studies that are still used to inform our treatment options today. Now we're turning our attention to new questions, understanding these variants that are emerging, what makes them spread so quickly, and whether they pose any danger for escape from vaccines. We're also interested in long COVID, why some people have persistent symptoms, and along with the severe symptoms, can we figure out pathways to interrupt those symptoms and treat new disease? And it's important to remember that these discoveries are important not just in this current pandemic, but because we need to be prepared for the next one. And we only have to look at the example of the HIV pandemic, which led directly to the development of new vaccine platforms, including the adenovirus platform and the mRNA platform, in our frankly failed attempt to develop an HIV vaccine, which are the basis of our current very effective COVID vaccines. So our research now is not only helping us to treat diseases we've never seen before, but those we've known about a while and those we have yet to see.
When most of us face stress, we wish to eradicate it. However, our bodies are actually built to embrace it. That's because stress is a key developmental role in our lives. The more stress we have, the better we perform, but only to an optimal point. After that optimal point, we start seeing the impact of stress on our physiology, and it affects our function, our health, our happiness. In my lab, we call this the backpack that we all carry. And very much like we regulate temperature through a process of homeostasis, we can manage stress. But what happens when that backpack gets too heavy? That homeostasis switches into a state that we call allostasis. That's when it starts having an impact in our physiology. So how do we protect ourselves? We build resilience. Resilience is a physics term. It means the coil bounces back to its original state. But I think we can do better than that. I think we can adapt. An adaptation means it bounces back, but to a better place, with more knowledge, more experience, and better health. But how do we bounce back? How do we get there? Is it in our nature, or is it based on our experiences? Well, as most of you know by now, the battle between nature and nurture is pretty much over. It is in the interactions between genes and environments that we see how our behaviors get managed and controlled. And it is the study of epigenetics that looks at those interactions. Thanks to one of our friends like you, our lab is able to collaborate with Alex Urban, a colleague and also faculty member in our Department of Psychiatry. He's a geneticist, and we are seeing how to apply the field of epigenetics to resilience. We have developed a model with stem cell-generated neurons and glia, mini simulation of brain composition that we call organoids. And what we do is we expose these to a hormone that we all secrete when we are stressed, named cortisol. My lab and others have found that cortisol, when secreted in high amounts, can actually alter very important brain regions during development. Through epigenetic analysis, we aim to identify those genes that actually can confer protection or vulnerability to this cortisol insult associated with stress. This information will provide better understanding of resilience, and it will help us incorporate this knowledge into our current programs and interventions that promote health and wellness. Interventions that heal those afflicted by stress and trauma. At the Early Life Stress and Resilience Program, for 25 years, we've been researching the psychological, biological, and social consequences of stress during development. We use this data and this information to develop interventions and also to disseminate them broadly. And they also help us inform policy. Key components of these interventions include the enhancement of executive function and emotion regulation. And in doing so, we strengthen frontal limbic pathways in our brain. In other words, we use neuroplasticity to our advantage. Our interventions empower our patients and provide them with self-efficacy and socio-emotional growth. With this new work on the organoids, we are at the precipice of a new frontier. After we flag key regions of interest, we will be able to confirm and reject this in animal models and identify potential points of entry for therapy. And who knows? Maybe someday we'll have social, behavioral, and biological vaccinations to protect us from the physiological effects of a heavy backpack.
Lesbian, gay, bisexual, transgender, queer, and other sexual and gender minority people are in every county in the United States. We make up approximately 6% of adults and 16% of Generation Z. Little is known about the health of LGBTQ+ people as a whole, and importantly, there are notable differences in LGBTQ subgroups. We are not one monolithic community. So we needed to study how the differences in our identity and our societal experiences influence our health. The healthcare needs of a transgender woman who's just starting hormones in her transition is very different than the healthcare needs of a cisgender lesbian woman, which are very different from those of a bisexual man. LGBTQ+ people are underserved, understudied, and vulnerable to poor health. But they likely have unknown health resiliencies. Because information about sexual orientation and gender identity has unfortunately not been collected and continues to largely not be collected in health studies, we have really a dearth of information about the health of LGBTQ+ people and the influences on that health, including medical therapies and social support networks. We really must conduct this research to ensure that the medical community, including the medical community at Stanford, is developing interventions to help combat disease and promote well-being and affirming therapies for everyone. Recent work from our group has found that negative experiences such as prejudice, discrimination, or victimization were actually correlated with negative physical health outcomes. Conversely, positive experiences such as being out or living in a warm, affirming, and safe place, those were correlated with positive physical health outcomes. I co-direct this work with Dr. Juno Obedin-Maliver, an assistant professor in obstetrics and gynecology, who regrets that she couldn't be here tonight as she's recovering from a recent surgery, but she's doing well. As physicians and scientists, Juno and I take a team science approach, and we wanted to figure out how we could serve all communities better, with a special focus on communities that are the most underserved and the most minoritized. Doing so will help the health of everyone. As graduates of Stanford Medical School, we knew that it was at a place like Stanford that we could find a research home to answer some of these burning questions. Stanford's commitment to equity was why we moved back here to join the faculty 2.5 years ago, and we created the Pride Study and the Pride Lab. The Pride Study is a national online study of LGBTQ adults. More than 22,000 folks have enrolled, and they help us answer the big overarching question. How does being LGBTQ how does being LGBTQ influence your health, both physical, mental, and social? There are thousands of research questions that we could answer. And in addition to the influence on physical health that I mentioned earlier, let me share a few other findings from our group. Currently, screening questions for problematic alcohol use are based on the sex that somebody was assigned at birth, such as being female or male. We wanted to understand how to screen somebody based on their gender. For example, should transgender men be screened differently than cisgender men? We ended up finding a single screening question that worked across many gender groups. We also study sexual and reproductive health. And we found that transgender men can and want to get pregnant and give birth. And we also found that they can get pregnant while taking testosterone, which was previously thought to be a rather effective contraceptive. To conduct this work, we designed and built our own digital research platform, and we continue to evolve that platform in order to develop new sophisticated tools to recruit participants, to have accurate and complete data collection, and to develop new ways to engage participants for many years to come. We have dozens of papers published and under review, and as part of our innovative engine, we have our Pride Lab. We're also building this group to train the next generation of LGBTQ health researchers. At any given time, we have more than 20 mentees in our lab, from high school students all the way through junior faculty members. And they're working on a variety of exciting projects, including cancer, COVID, family building, sexual function, disability, as well as things like resiliency and joy. Mentees present their works during weekly Weeks in Progress meetings and collectively work together to tackle some of the most pressing research questions in LGBT health. Anthony Foe, a postdoctoral scholar in our group, studies things that influence human papillomavirus infection among transgender people. Anthony recently received a prestigious Stanford Propel Fellowship Award, and he found that transgender people were more than twice as likely, compared to their cisgender counterparts, to get the human papillomavirus vaccine if they used social media, and that may be due to validation from their peers. Our research careers began at Stanford as medical students in the mid-2000s, thanks to Stanford's commitment to innovation and diversity. We're delighted to be back at Stanford as part of the new LGBTQ+ health program here, and we're working to enhance the diversity in science and in medicine. Every morning, I'm invigorated at the rapid evolution of this field and the promise for high-impact research that will make a meaningful difference in the lives of LGBTQ people everywhere. We will see meaningful advancements over the next years in LGBTQ health, and I'm delighted to be a part of this field and to do it at Stanford. Thank you so much.
My students and I believe that some of the richest opportunities for driving innovation lies at the interface of fields. And in particular, we were interested in taking some of the tools and technologies from the computer industry used to make integrated circuits and see if we can design new drug delivery carriers and new vaccines. And why we thought that was because if you look at the dimensions of Moore's law, which has been driving the size of integrated circuits to smaller and smaller feature sizes, these top-down technologies have gotten to the point of being able to replicate the dimensions associated with biology. So if you start to look at the size of cells and bacteria and now viruses that were on the order of nanometer scale, becomes a great opportunity to use these tools to make really precise carriers. With this approach, we've been able to design particles that are encapsulating drugs and vaccine components and designed out of chemistries that have the ability to seek out cells, get inside cells, and because of the unique environment inside cells, can selectively degrade these particles. And if our goal was to fix a cell, maybe doing gene regulation, could release the cargo. Or if the goal was to try to delete the cell, kill the cell, thinking about oncology, we could release a chemotherapeutic. And this has turned out to be a really great approach for doing targeted drug delivery. Now, one of the biggest challenges, though, is that even though we're working at the nanometer scale, this is still fairly large. And some cancers are protected by a fortress, a stroma, that protects the cancer cells from these chemotherapeutics. And so recognizing that even nanomedicine was not successful for treating certain cancers, in particular pancreatic cancer, we designed devices that could be surgically implanted right on top of the tumor, and we can use a mild electric current to drive chemotherapeutics directly into these tumors and avoid some of the systemic side effects commonly found with doing an intravenous delivery. And so if you can deliver the drug directly to the tumor, you can have tumor regression. In particular, in pancreatic cancer, we published in Science Translational Medicine to be able to reduce the tumor volume by 40%, making more people eligible for surgery in pancreatic cancer. Now, this turned out to be really fruitful. In a broader sense is the opportunities for delivering drugs and vaccines to the targets are quite important. So take, for example, vaccines today. We all got the coronavirus vaccine, and it was an intramuscular vaccine. It was delivered to the muscle. But what's also very interesting to realize is that in the dermis, we have many more, a higher concentration of the target cells for these vaccines in the dermis than we do in the muscle. In fact, it's 2 to 3 orders of magnitude higher in the dermis than in the muscle. So we were interested, could we design microneedles that could be effective to deliver directly to the dermis where these target immune cells are, and could we do it out of a design that was pain-free, anxiety-free, and do it in a solid state instead of in liquids. And so our approach for doing this was to use the tools of 3D printing. 3D printing is what brought me to California from the East Coast, and developed a technology that we spun out into a company that is able to directly 3D print a wide range of products. And what we've done here at Stanford is that we've designed a 3D printer with really small feature sizes to make microneedles. You can see the illustration in the designs here, and these have been very effective at delivering vaccines to the dermis. We just had a paper come out in the Proceedings of the National Academy of Sciences today where we see a 50-fold increase in the antibody response by delivering the same vaccine to the dermis than we do through subcutaneous injection. These have great opportunities for not only delivery, but can we also use these patches in a pain-free way to extract interstitial fluid to replace blood extraction so that we can do biomarker detection and biomarker measurements just like you do with blood draws. And so we're really interested in using a pain-free approach for these kinds of analyses that typically would use a blood draw and do it with interstitial fluid. And we think this has got the potential for very rapid testing, almost as common to do molecular testing that you would do with checking your watch. Thank you.
The development of safe, effective COVID vaccines in record time was an extraordinary triumph of science. At the same time, the other side of that triumph is clear in our struggle to vaccinate the country and the world with speed and equity. There's a saying in public health, vaccines don't save lives, vaccinations do. And we're really seeing that contrast matter between breakthrough in discovery and breakdown in delivery. We're in a golden age of innovation, but we've got to match our achievements in technology and medicine with the same sort of progress in access and affordability, in law and policy, if we're going to translate all of that innovation into better health and better lives for people around the world. This is the domain of health policy. We use the tools of quantitative and social sciences to drive evidence-based solutions at population scale, and thinking especially about those who are too often left behind. Health policy is the bridge that can lift breakthroughs over the chasm of breakdown. Stanford Medicine just this month has launched a new Department of Health Policy to unite and catalyze university-wide collaboration in this area. And what a moment this is for health policy at center stage during this pandemic. For me, a sign of that visibility is that my teenage daughters actually have some idea about what I do for a living now. But more fundamentally, COVID reminds us that health policy touches so many decisions that affect us all. I remember really well that day in early March 2020, when I knew that I would be putting aside whatever I could to dive into COVID policy work. Because I had some skills that could be useful in a once-in-a-century public health emergency, and because this is what we do in health policy. And I remember the days that followed as faculty gathered together and students came over to ask, what can I do? How can I help? Like never before, the need for health policy analysis was everywhere you looked, and we knew we had to answer that call. So we answered it by absorbing the flood of new data, by connecting the dots with modeling and forecasting, working directly with policymakers to try to tie all of this together and translate it into the guidance that they needed for urgent action. Here's what health policy analysis looks like at the speed of COVID. On Friday afternoon, our team finishes up our latest analysis on how we might speed up the allocation of vaccines to the hardest hit neighborhoods to try to address disparities. The next Monday, the student who led that work is presenting our recommendations in a briefing with the leaders of the health department and the governor's office. And the following Wednesday, we're reading about a new allocation policy in the papers. And the day after that, somebody's really mad about the policy. But health policy is more than emergency response. It's how we prepare for and ideally prevent the next health crisis. It's the problems of aging world, cancer, heart disease, dementia. It's the other epidemics, obesity and the opioid use crisis and gun violence. We will turn the page on this pandemic, and when we do, there'll still be plenty of work left to do in health policy. We're ready to tackle these problems on a big stage, thinking beyond decisions that affect health now, towards guiding strategic investments that can shape health for decades to come. Stanford is a world leader in creating solutions for health challenges. We also have the expertise to understand where those solutions fit in health systems, to forecast the big trends in health that'll matter, and to think in systematic, data-driven ways about the decisions and the events that can drive those trends in one direction or another. We want to connect those dots to devise an explicit roadmap to prioritize innovations that have the greatest potential to improve population health and reduce disparities. Take, for example, Alzheimer's. Where might we look for the biggest health returns from new discoveries in diagnostics or prevention or treatment? Thinking across diseases, how would those impacts compare to progress we might make against diabetes or childhood cancer or mental illness? And in order to avoid breakdowns while we cultivate breakthroughs, where might we look for innovations in delivery and financing and data systems to make the technologies we develop accessible and affordable to everybody? We have all the elements at Stanford to answer these questions. We want to bring those elements together in a new initiative called the Global Health Strategy Lab. With appropriate support, health policy research at Stanford can roll out a blueprint for innovation that delivers impact, to transform human health over our lifetime.
I'd like to talk to you about opportunity. The opportunity to change not just one life, but many lives. Every time I come to work here at Stanford, I'm humbled about where I find myself. As a graduate of Stanford Medicine, a professor of radiation oncology and neurosurgery, and as the associate dean for the medical student admissions. In January every year, I am excited beyond measure because I have this wonderfully fulfilling opportunity to do this one task that I know is so important. And that is to make these personalized phone calls to students to notify them about their acceptance to Stanford Medicine. It's really amazingly gratifying to hear these shouts of joy and these tears of joy, because for these students who have spent years in preparation and a full year just preparing, they have this anticipation, and this moment is the validation that their hard work has paid off. And so my excitement is that through this kind of act, I invariably change people's lives. This often causes me as well to think back and to reflect when I received my own notification, but that time it was by mail. And as a first-generation student, I am from a small town in Delaware. Neither of my parents went to college. I had these concerns about whether or not I could even make the reality of this Stanford education because of financial hardship. But when I arrived, I had never even traveled on an airplane. I'd never been to California. But when I arrived on this campus, I was mesmerized by Palm Drive and Memorial Church in the distance. And I immediately felt this feeling that I belong. And so I have not actually left. And so I'm feeling so grateful because through the generosity of strangers, my family has actually been changed. And out of our grief and out of our financial despair, I have been able to contribute to novel research discoveries, to become the co-director of a novel program that changes patients' lives, cyberknife radiosurgery, to become a leader in my field. And through this role of being an associate dean of admissions, to witness this beautiful cycle over and over again as the chief gatekeeper to the profession and witnessing the promise of the next generation. Now, every year we matriculate 90 students, and these 90 students are this eclectic group of accomplished scholars, artists, athletes, and inventors, first-gen trendsetters like myself, disadvantaged individuals from backgrounds with racial and ethnic groups who are underrepresented in medicine, and leaders who have served on the front lines of the COVID pandemic. We are fortunate to have the Arriaga Fund and others like it to be able to support these students to make a Stanford Medicine education a reality so that they can share their enormous gifts with us. So today, I'd like to introduce you to a few of the students who accepted my call. We have Alvaro, who is this tenacious student who's on a journey to become a physician scientist as an MD PhD candidate. And Abu, a second-year medical student whose personal experiences have been just truly inspiring to us all. These are but a few of the 100 stories that we could share with you about the opportunities that you have made possible. Without further ado, Abu.
Thank you, Dr. Gibbs. Every once in a while, you get to experience a moment in your life that changes everything. And today, I'm going to be sharing a few of those with you. So the first moment was back in 2013 I was in Sierra Leone, and this is when the Ebola outbreak had hit. I vividly remember this moment because first it was flyers on every corner of the streets, and these were quickly replaced with humans dressed in bleached white hazmat suits going from community to community, picking up dead bodies and also transporting sick individuals. Nothing like this had ever happened before. It was absolutely frightening. Everyone around me was scared. I was scared. But the worst part of it all, which I'm sure everyone in this room is familiar with, is that it absolutely sucks when there's nothing that you can do about it. My friends lost family members. I lost family members. And the more this continued and the more I felt so helpless on the side, I decided that I wanted to pursue medicine as a career with the hope of at least paving the path to make sure that we have a better way forward. And that brings me to my second moment. I was 15, I moved to the US, and this was my first time living away from my family and my home. With the experiences from the Ebola still fresh in my mind, there were a lot of things that I wanted to do, but I had to first learn how to survive in my new environment. It was the first of many firsts, from applying to colleges, to taking classes and navigating the pre-med path. On most days, it was incredibly challenging, and there was not really a clear sight forward. But I just had to trust that things will eventually fall into place. And they did. And that brings me to my third moment. And this one involves Dr. Gibbs. It was when I got the call that I had gotten into Stanford Med. To picture it, it was late at night. I was already in bed in Ohio, and I got the call, and I jumped so hard I hit the ceiling, and the light bulb went flying, and it shattered. But I didn't care. I just phoned my mom in Sierra Leone, and I gave her the news, and we just screamed on the phone. Now, for you to understand what that meant, this scream to me was the culmination of years of sacrifices that was poured into a dream that was now coming to fruition. This scream was not just hope for myself, but also for my family and for my community as well. This scream was also, oh no, it was me realizing that I had gone into medical school and that I was actually going to do this. But this scream was also gratitude, knowing that I will not have to worry about financing my education, that I can just focus on learning and growing. And during my time here at Stanford, that's exactly what I've been able to do. Through my research, I get to listen to the stories of Ebola survivors and their family members on the impact that the epidemic had on them. As manager of the Stanford Cardinal Free Clinics, I get to go in every Saturday to work with other individuals who are just equally as passionate to addressing some of the health disparities we experience in our community here. I get to go into the community to understand really vaccine hesitancy in Black communities, but also I get to do this work and advocate for equitable vaccine distribution, not only in Sierra Leone, but globally as well. It is truly incredible, and I can't wait to continue doing this for the rest of my life. Now, in all of those circumstances I mentioned, someone had to guide me through some of those. Someone took a chance in me, but it is through your generosity that I truly get to live my dreams, to pave a path forward for my community so that things will be better than it was growing up. So from the bottom of my heart, thank you. Alvaro?
Hi. This evening I want to tell you how 3 phone calls opened the door to unimaginable opportunities for myself. In late February 2016, the medical school interviews had just ended for me, and I was working at a biotech startup. I was in the middle of preparing for experiments when I received a phone call at 2 p.m. Hello? Hi, Alvaro. This is Dr. Iris Gibbs. I got scared. My heart started pounding. I was thinking a million different things. Did I forget to turn something in? Was it April Fool's Day? Could this be it? I composed myself and waited. Then I listened. Congratulations, acceptance. I felt so relieved and an immense sense of accomplishment. We did it, I thought to myself. On that day, this was for my family. My parents had worked very hard and tirelessly for many years, from the day when they decided to pack their things and move from Peru to the US in 2003, to every single day where they worked tirelessly, multiple jobs, to give an opportunity to myself and my sister, to give us a better chance to do something better. I was a late bloomer. It wasn't until community college when I decided to pursue medicine. For many years, I was the de facto translator for my parents, including their medical visits. It was a routine of blood tests, medical exams, and medications. But this time it was different. My sister, Jackie, was sick. She had gone to the doctor and they could not figure out what was happening with her. The doctors at the county hospital decided to refer her to Stanford. Here, they discovered that a small tumor in her brain was making too many hormones, making her ill. It was that day that I decided to become a neurosurgeon. Deciding to become a physician was the easiest choice I made. Everything else to come was not. I switched majors from engineering to biology. I signed up for science courses, and I decided to create a plan to transfer to a 4-year university. After many years, I was accepted to UC Berkeley. It was hard work, but it was well worth it. Graduating from Berkeley was an amazing thing. Finding a job was my next goal. From a Craigslist ad, I was able to find a job as a lab tech, mixing chemicals and washing glassware. This allowed me to take MCAT courses late at night 4 times a week. I took the MCAT, applied, and interviewed at various medical schools. And so I was just waiting to hear back. So when Dr. Gibbs called, that meant that I get a chance to pursue my dream. She opened the door to a new opportunity. The second phone call occurred during revisit week. This time I was at Stanford meeting my potential classmates and deciding between 2 medical schools. Dr. Gibbs knew that I wanted to be a neurosurgeon. While discussing this, she called me and she told me, "Would you like to meet one?" Up to this point, I've never met a neurosurgeon in my life. She got on the phone and called one of her colleagues, Dr. Lee. Dr. Lee said that he was ready in 15 minutes. I dropped everything, ran from the medical school to the cancer center, and started chatting with him. He told me the amazing things happening at Stanford in the medical school, the wonderful research opportunities in neurosurgery, and the innovation happening here. It was such a thrilling experience. I could finally see how both being a physician and a researcher was a possibility here. Now, I'm pursuing a combined degree and I'm working towards developing a therapy for Krabbe disease, a genetic disorder that affects infants' brains. All of this seems surreal to me. 3, the last phone call was Dr. Gibbs again. This time last month, she asked me to be part of this event and tell a little bit about myself to the people who made my dream possible. Honestly, I am so grateful to be here today, and from the bottom of my heart, thank you for your kindness, your goodwill, and generosity.
Wow, what an evening. It's evenings like these that give me pause and a sense of wonder to see that even under the tremendous weight and responsibility, Stanford Medicine leads in advancement in research and healthcare. From the very beginning of the pandemic, with the challenges of learning the lessons of a brand new common enemy, a new BSL-3 lab, a new and accurate test, a broad sampling of patients across the spectrum of disease, from exposure to pre-symptomatic illness to the ICU, into conducting clinical trials in tents in the rain. On behalf of Stanford Medicine, thank you. To the staff, faculty, students, residents, and fellows who came together to care for patients and each other. To police, fire, ambulance services that partnered with us to meet the fears and needs of those affected by the pandemic. Thank you. To the community, you, our sustaining partners, making sure frontline clinical staff had what they needed, from personal protective equipment, nourishment, housing, for those of us who are working, for those of us who are exposed, and for those of us who unfortunately contracted the virus. You cannot imagine how much those supportive items meant. A coffee, a meal, my personal favorite, bubble tea, stabbing those tapioca pearls with a straw for 10 minutes, a very welcome diversion from what inevitably came next. Your support gave weary, exhausted healthcare providers a sense that we were not alone during a time that felt very, very lonely. The impact of that support is what kept us going. You so generously supported our scientific and healthcare efforts to uncover the seemingly endless layers of this pandemic, and we will continue. On behalf of Stanford Medicine, a heartfelt and grateful thank you. Please enjoy the rest of your evening.